There is this quote from the late Princeton economist Uwe Reinhardt that I think just completely shatters the illusion of how we finance medicine in the United States.
Oh, yeah. He had a real knack for cutting right through the noise.
He really did. He spent his entire career observing this massive machinery, and he ultimately concluded that our system is, well, his words were, bewildering and inefficient, almost beyond human comprehension.
Which is saying something coming from a Princeton economist, you know.
Right. And he pointed out this really fundamental, almost ingrained American paradox. Like, on one hand, we demand absolute access to top-tier healthcare, but on the other, we fiercely refuse to confront the reality of actually paying for it.
Exactly. We want the care, but we reject the math.
We totally reject the math. And because of that collective cognitive dissonance, nearly 18 cents of every single dollar in the entire U.S. economy just vanishes. It vanishes into this financial labyrinth that very few people actually understand.
It is a stunning paradox. I mean, Reinhardt wasn't just being dramatic when he said it was beyond human comprehension. He was looking at the sheer volume of capital. We're talking trillions of dollars.
Trillions.
Yeah, trillions moving through a system that actively resists standardization.
We've built an economic engine where the normal mechanisms of supply, demand, and price transparency have just been systematically neutralized.
Which is exactly what we are dissecting today in this deep dive. We are taking a massive stack of clinical and financial text, including some really heavy-hitting operational manuals by Buppert, Waxman, and various industry analyses, to basically map out the subterranean architecture of U.S. health insurance and provider reimbursement.
It is quite the map, too.
It really is. Our mission today is to trace exactly where $3.8 trillion flows, how a highly specific string of alphanumeric codes essentially dictates the clinical care you receive, and why an entire hidden army of advanced practice registered nurses is currently trapped in this bizarre systemic billing loophole. Because the mechanics of how this money moves, it dictates everything from the length of a clinical visit to the actual physical layout of the hospital floor. It's the enviable scaffolding of modern medicine.
And I want to say right up front to you listening, you are participating in the system. This isn't just some abstract accounting exercise.
No, not at all.
The mechanisms we are breaking down today form the invisible architecture of every single encounter you have ever had with a provider. When you're sitting on the exam table, you are sitting inside this economic engine.
Which is a really sobering thought when you realize how dysfunctional the engine actually is.
Exactly. So to really grasp the scale of the dysfunction, we have to start with the macro picture, right? The broken economics of that $3.8 trillion expenditure.
Right. And to contextualize that number, in 2019, that $3.8 trillion represented nearly 18% of the U.S. GDP.
18%.
Yeah. And if we look back to 1960, healthcare hovered around just 5% of the GDP. So it has exploded.
Yeah.
We are currently spending double what our wealthy, industrialized European counterparts spend on average.
But the capital outlay isn't even the issue in isolation, is it? It's the return on investment.
Exactly. The ROI is just abysmal.
Yeah, the source data points out that despite that 18% GDP expenditure, the United States consistently ranks at the very bottom among its peer nations for life expectancy, while simultaneously holding the highest burden of chronic disease.
Which, from an economic standpoint, makes absolutely no sense.
Right, because in a traditional market, that level of capital investment would force a course correction. If you pay a premium, you expect a premium product.
You do.
If a sector absorbs a fifth of the national economy and produces inferior outcomes, traditional market forces should dismantle and optimize it.
But see, that assumes healthcare operates as a traditional market, which it fundamentally does not. It just does.
So why doesn't it?
Well, to understand the root of this inefficiency, we really have to revisit Kenneth Arrow's seminal 1963 paper. Arrow was a Nobel laureate, and he basically outlined why healthcare constitutes an imperfect economic market.
An imperfect economic market?
Yeah. He identified 3 distinct pillars that cause conventional economic theory to just collapse when you apply it to medicine.
Okay, lay them out for us.
So the first pillar is the inherent uncertainty of the product.
Uncertainty in the sense that, the biological response to a treatment isn't a guaranteed transaction?
Exactly. You can't just return a surgical intervention if it fails to resolve your chronic pain. and a pharmaceutical might have a wildly different efficacy profile from patient A to patient B. The commodity itself is just inherently volatile.
Okay, that makes sense. So what is the second pillar?
The second pillar arrow identified is the asymmetry of information.
Ah, asymmetry. So in a normal functional market, the buyer and the seller possess relatively symmetrical knowledge about the product and its value, right?
Right. But in healthcare, that symmetry is entirely fractured. The patient holds the historical data regarding their symptoms, but they lack the pathological expertise.
And the provider holds the clinical expertise, but they're often operating with an incomplete patient history.
Exactly. And the most critical piece of that asymmetry, the part that really breaks the market, is that at the point of decision-making, neither the patient nor the provider usually knows the actual financial cost of the intervention they're agreeing upon.
That is just wild to me. The pricing is completely decoupled from the point of sale.
Totally decoupled.
Yeah.
Which leads us directly into Arrow's third pillar, which is the non-marketability of risk. In economics, this is commonly referred to as moral hazard.
Moral hazard. I've heard that term used a lot when talking about insurance.
Yes. Because healthcare costs can be so catastrophic, we have to rely on third-party insurance to distribute the risk. But the mere presence of that insurance alters consumer behavior.
Because the consumer isn't feeling the direct financial sting of the service.
Exactly. When a third party absorbs the financial liability, the consumer, the patient, is economically insulated from the true cost of their care. And that incentivizes a higher utilization of services than they would ever agree to if they were paying entirely out of pocket.
So if we synthesize Arrow's three pillars, engaging with the U.S. healthcare system is basically like operating in this hyper-complex commodities market where you are forced to purchase goods blindfolded.
That is a great analogy.
Like you are a consumer making high-stakes, potentially life-altering purchases without knowing the price.
Yeah.
You're relying on a broker, your doctor, who also doesn't know the final price. And then you pass the ultimate invoice to a third-party underwriter who will unilaterally decide the final valuation months after the transaction has already occurred.
It's a profound market failure. I mean, it really is. And because we can't rely on normal consumer choice or price competition to regulate this ecosystem, the only way to really understand its trajectory is to follow the actual flow of capital.
We have to map the $3.8 trillion to see who is actually holding the leverage.
We do.
Well, let's follow that money trail. The texts break down the 5 major payer categories, and they reveal that 73% of all U.S. healthcare dollars are routed through health insurance.
Right.
But the dominant force, the single entity holding the absolute largest share of leverage, is the federal government. Medicare and Medicaid combined account for 37% of total national spending.
And that 37% is everything.
Yeah.
Because CMS, the Centers for Medicare Medicaid Services, they control that massive share, so they function as the ultimate market maker.
They set the rules of the game.
Exactly. Commercial insurers almost universally shadow CMS policy. So when Medicare alters a reimbursement mechanism or, say, requires a new documentation standard, the entire private sector eventually falls in line just to maintain administrative parity.
And the scale of the populations covered under those public programs is just staggering, especially when you look at it post-ECA.
Oh, absolutely.
The sources show that Medicaid expansion drove the uninsured rate down from a peak of nearly 18% in 2010 to just under 11% by 2019.
Which is a massive public health victory on paper.
On paper, yeah. But even with that expansion, the remaining uninsured population creates this massive systemic strain, and it heavily impacts working families earning under $25,000, right? Because they often utilize the emergency department as their primary point of access.
Which, as we know, is the most expensive, least efficient node in the entire system.
Exactly.
And that dynamic is crucial when we look at how the government actually partitions its funding, particularly within Medicare. Because the structure of Medicare isn't a monolith.
Right, it's alphabet soup.
It really is. It's segmented into these specific risk pools, which creates an intensely fragmented billing environment. So you have Part A, which covers the physical infrastructure of inpatient care, like the hospital bed itself, or a skilled nursing facility.
Okay, so that's Part A. What about Part B?
Part B covers the professional outpatient services and the rounding physicians.
So wait, let me get this straight. A single patient admitted for a cardiac event generates a highly bifurcated billing cascade. Like, the hospital submits under Part A for the room and board, while the cardiologist bills under Part B for the consultation.
Yes, they create separate, parallel revenue streams for the exact same clinical episode.
That sounds incredibly complicated to track.
It is. And then we have Part C, which is Medicare Advantage, where CMS essentially outsources the risk management of both A and B to private managed care organizations.
Yeah.
And finally, Part D, which is for the pharmacological piece, the prescriptions.
So when you map where those segmented dollars ultimately land across the broader $3.8 trillion landscape, the distribution highlights a really massive structural bias, doesn't it?
It definitely does.
The numbers in the deep dive sources show that 31% of all healthcare dollars flow directly into hospitals, 20% goes to physician and clinical services, and 10% is captured by prescription drugs.
But, the statistic from the source text that truly contextualizes that distribution is the actual nature of the care being purchased.
Right.
Over 75% of all healthcare expenditures in the U.S. are consumed by the treatment of chronic conditions.
75%?
Yeah, three-quarters of the budget. Meanwhile, a mere 8% of adults receive all recommended routine preventative services.
The economic disparity there is just jarring. I mean, we are allocating three-quarters of our national budget to manage complex, cascading pathologies like diabetes, heart failure, advanced COPD, while simultaneously starving the preventative interventions that would preempt them in the first place.
Exactly.
Yeah.
We have engineered a highly reactive, capital-intensive infrastructure that is optimized almost entirely for late-stage acute intervention. We are financing disease management. We are not financing health preservation.
Because the economic incentive structures historically rewarded intervention over prevention, interventions generate higher acuity billing codes, right?
Precisely. And this makes the data surrounding the 2020 COVID-19 pandemic incredibly alarming from an actuarial standpoint.
Oh, wow. Yeah. The sources note that approximately 41% of U.S. adults deferred medical care during the initial waves of the pandemic.
And that isn't just a temporary dip in utilization. In a system where 75% of the capital is dedicated to chronic disease management, a 41% deferral rate means routine screenings, A1C checks, and hypertension management just completely halted.
So what's the downstream implication of all that deferred care?
It's a massive delayed waves of high acuity claims. I mean, a deferred mammogram doesn't eliminate the cost of oncology care. It simply pushes the diagnosis into a later, much more complex stage.
Which requires significantly more expensive Part A and Part B expenditures down the line.
Exactly. The system is currently bracing for the financial impact of those unmanaged chronic conditions progressing to acute crises.
And knowing that this wave of deferred chronic complexity is incoming, CMS and the commercial payers realize they can't simply maintain the historical status quo of just writing blank checks.
Right. The capital pool isn't infinite.
Exactly. So this existential financial threat is what has driven the aggressive ongoing evolution in how providers are reimbursed. It's this incredibly painful systemic transition from volume-based to value-based care.
It is probably the most significant structural shift in modern medical history. Because for decades, the system operated on a pure fee-for-service model.
Fee-for-service.
Yeah. The logic was simple. A provider performs an intervention. The payer reimburses for that specific intervention.
But as we discussed earlier with Kenneth Arrow's moral hazard, fee-for-service inherently incentivizes maximum volume, doesn't it?
It does. It rewards the sheer quantity of interventions, completely regardless of their actual clinical efficacy.
Right. Like if a hospital's revenue is directly tied to the number of MRIs performed or the number of days a patient occupies a bed, there is zero financial incentive to resolve the patient's issue quickly or efficiently.
Not at all.
The longer the stay, the more line items generated on the bill. So, to counter that inflationary spiral, we saw the introduction of fixed price models, specifically diagnosis-related groups, or DRGs.
DRGs fundamentally altered hospital administration. Because instead of paying a la carte for every single bandage and blood draw, CMS began paying a flat, predetermined rate based on the patient's specific diagnosis upon admission.
So, if a patient is admitted with uncomplicated pneumonia, the hospital just receives a fixed sum.
Right. The financial risk is suddenly transferred from the payer directly to the provider.
Because if the hospital can resolve the pneumonia efficiently and discharge the patient using fewer resources than the DRG payment covers, they get to capture the margin as profit.
Exactly. But if the patient develops complications and requires, say, a 3-week ICU stay, the hospital absorbs the loss.
Wow. So in theory, it forces operational efficiency. But the source material is really quick to point out the behavioral economics that emerged from this DRG model.
Oh, yeah. Because when you tie reimbursement to diagnosis codes, you inadvertently incentivize upcoding.
Upcoding.
Yeah. Hospitals started investing heavily in clinical documentation specialists. Their primary function is to scrutinize the medical record to capture every possible comorbidity, effectively moving the patient into a higher-paying DRG bracket.
And the texts also point out that a strict DRG model creates a really perverse incentive to avoid admitting highly complex, socioeconomically vulnerable patients, because the hospital knows they are statistically likely to consume resources that far exceed the fixed payment.
Which is exactly why the evolutionary timeline didn't just stop at DRGs.
Right.
CMS recognized that efficiency doesn't necessarily equal quality.
Right. Simply discharging a patient quickly just to capture a profit margin doesn't matter if that patient bounces back to the emergency room 3 days later.
Exactly. So the current paradigm has shifted toward value-based purchasing, or VBP. This is where CMS really weaponizes its 37% market share to enforce the Institute for Healthcare Improvement's triple aim.
The triple aim, let's break that down. The sources define it as improving the experience of care, improving the health of populations, and reducing per capita costs.
Right. And to actually achieve this, CMS transitioned from simply offering little bonuses to deploying severe financial penalties for poor outcomes.
They brought out the stick.
They absolutely did. The Hospital Readmissions Reduction Program, or HRRP, is a prime example of this punitive leverage.
The mechanics of HRRP are fascinating because they fundamentally redefine the boundaries of a hospital's responsibility.
They do. Under this program, CMS targets specific, really high-cost conditions. We're talking acute myocardial infarction, heart failure, pneumonia, COPD, and elective hip or knee arthroplasty.
Okay, so if a patient is treated for one of these conditions, successfully discharged, and then unexpectedly readmitted to any hospital within 30 days, what happens?
The original hospital suffers a reduction in their future Medicare payments.
Wait, really? Even if the readmission is at a completely different hospital?
Yes. The hospital is no longer just responsible for the acute intervention inside their four walls. They are financially liable for the immediate post-discharge stability of the patient.
So this forces acute care facilities to heavily invest in care coordination, outpatient follow-up, and medication reconciliation, because the financial penalty for a readmission far outweighs the cost of just paying for a transitional care nurse to make a few phone calls.
Exactly. But the penalties extend far beyond just readmissions. We also have the Hospital-Acquired Conditions, or HAC program.
HAC. And this targets iatrogenic complications, right? Harm caused by the healthcare system itself.
Right. Things like central line-associated bloodstream infections, or CLAB-SI, and catheter-associated urinary tract infections, CAUTI.
And the enforcement mechanism here is incredibly aggressive. The texts explain that CMS actually ranks hospitals based on their HAC scores, and the bottom quartile, the worst-performing 25% of hospitals nationwide, automatically lose 1% of all their Medicare payments across the board.
Which is huge.
Yeah.
A 1% reduction across every single Medicare discharge is a catastrophic blow to a hospital that's probably only operating on a standard 2% to 3% margin anyway.
It just immediately evaporates their operating capital.
It does. And the enforcement becomes even more absolute when we look at the third category, detailed in the text's never events.
Never events. Just the name alone is ominous.
It is. The National Quality Forum maintains this list of never events, and they are basically egregious, highly preventable errors.
Like performing surgery on the incorrect anatomical site.
Exactly.
Mm-hmm.
Or retaining a foreign object post-surgery, administering incompatible blood products, or a patient developing a stage 3 or 5E pressure ulcer while admitted.
And since 2009, CMS's policy on never events is brutally simple. They just refuse to pay.
They completely refuse. They will not reimburse the hospital for the care associated with the event, nor will they cover any downstream costs of rectifying the error.
The hospital just absorbs 100% of the financial liability.
100%.
Which creates an environment of intense, almost microscopic operational pressure. And this is the friction point that fascinates me. The financial mandates, the threat of millions of dollars in penalties, they are established by executive leadership in the boardroom, right? But the execution and the liability fall squarely on the frontline bedside clinicians.
That is the crux of the issue. The CFO isn't the one maintaining the sterile field during a central line insertion to prevent a CLAB-SI.
No. The financial survival of the entire institution basically rests on the procedural perfection of a floor nurse working hour 11 of a 12-hour shift.
Exactly. The burden of this macroeconomic policy is carried entirely by the physical labor of the clinical staff. And it's not just clinical perfection they have to maintain either. It's customer service.
Right, which brings us to the HCA-HPS surveys.
The Hospital Consumer Assessment of Healthcare Providers and Systems. HCA-HPS is a standardized, randomized survey distributed to adult patients post-discharge.
And it measures the patient's perception of care. Things like nurse communication, physician communication, responsiveness of the staff, cleanliness, and even the quietness of the hospital environment.
And, this isn't just a Yelp review for internal quality improvement.
No, the texts highlight that the person and community engagement domain, which is derived directly from these HCA-HPS scores, accounts for 25% of a hospital's total performance score for value-based purchasing.
25%. Meaning a significant portion of a hospital's revenue is literally contingent on whether a randomly selected patient felt the room was quiet enough at night.
The subjective experience of the consumer has been hardwired right into the reimbursement algorithm.
It has, which means that the administrative apparatus of the hospital must meticulously document every single interaction, intervention, and diagnosis just to defend their outcomes and justify their billing under this intense scrutiny.
And to navigate this, the entire industry relies on a highly complex proprietary language of alphanumeric codes to translate clinical reality into financial data.
This is the operational core of the system. CPT and ICD-10.
Yes, these two coding manuals essentially govern the flow of the entire $3.8 trillion. Let's isolate CPT first. Current procedural terminology, which is maintained by the American Medical Association.
Right. CPT dictates the what. What exact procedural intervention or intellectual labor did the provider perform?
And within primary care, the engine of this system is the evaluation and management, or E&M code set.
E&M codes essentially distill an entire patient encounter into a 5-digit numeric sequence. A common example is 99204.
Which represents a moderate complexity visit for a new patient, right?
Exactly. The nuance lies in how a provider justifies billing that specific level of complexity. Recent structural updates to the E&M guidelines allow providers to calculate this based on either the total time spent on the date of the encounter or the complexity of the medical decision-making, the MDM.
And the MDM calculations where the true clinical translation happens, isn't it? It's not arbitrary at all.
Oh, not at all. To legally bill a moderate complexity code based on MDM, the provider must satisfy highly specific criteria across 3 elements: the number and complexity of problems addressed, the amount or complexity of data reviewed, and the risk of complications or morbidity to the patient.
It requires such meticulous charting, like a provider might need to document that they manage 2 stable chronic illnesses, independently reviewed external radiological images, and discussed prescription drug management, which carries a moderate risk of toxicity.
And if they fail to document any one of those elements clearly in the chart, an auditor will just downcode the visit, stripping revenue right out of the clinic.
So CPT captures the procedural complexity, but the payer won't reimburse that CPT count unless it is perfectly justified by the diagnosis, which is where ICD-10 comes in.
The International Statistical Classification of Diseases.
I have to say, I found the historical context in the source material regarding ICD completely captivating, because it didn't originate as a billing tool.
No, not at all. It originated at the 1851 Great Exhibition in London as an epidemiological tracking mechanism.
Wait, 1851?
Yeah. Early 19th century medicine had basically no standardized nomenclature. Mortality records were clinically useless because physicians just used colloquial terms. So the international medical community recognized that to track public health trends and infectious disease outbreaks, they desperately needed a universal statistical classification for causes of death.
So it was born out of this noble public health imperative to track mortality. But over a century and a half later, it has mutated into the ICD-10, which was mandated in the U.S. in 2015, and is arguably the most granular, hyper-specific billing requirement in the world.
Oh, absolutely. We are no longer just tracking consumption. We are dealing with 7-character alphanumeric codes that demand an astonishing level of anatomical and situational specificity.
Let's talk about the architecture of an ICD-10 code, because it is rigid.
Very rigid. The first 3 characters denote the broad category of the disease or injury. The subsequent 3 characters drill down into the specific etiology, the precise anatomical site, and the severity.
And then there's the 7th character.
Right. The 7th character functions as an extension. It captures details like the episode of care, whether this is an initial encounter, a subsequent encounter, or a sequela resulting from a previous injury.
The sources cite a specific example that really highlights this granularity, and I love it. Abnormal findings on screening for neonatal hearing loss.
Right. A clinician cannot simply write a narrative note stating the infant failed the test. They must isolate the exact alphanumeric sequence that perfectly describes that unique clinical scenario.
If the CPT code is the invoice for the labor, the ICD-10 code is the legal justification for why that labor was medically necessary.
And if there is any mismatch between the two, If the ICD-10 code doesn't definitively prove the medical necessity of the CPT code, the payer's automated adjudication system just immediately denies the claim.
To put this in perspective for you listening, imagine operating a global logistics firm. But instead of tracking standard shipping containers, your manifest requires you to generate a unique 7-character encryption key for every single item based on its origin, material composition, structural integrity, and the exact specific route the driver took to deliver it.
That is exactly what it's like.
And if one character is mistyped, the entire shipment is confiscated without payment. That is the administrative reality confronting a primary care provider during a standard 15-minute appointment. They are simultaneously conducting clinical diagnostics and executing complex financial cryptography,
Which obviously requires an immense amount of uncompensated administrative time. But there is a really crucial labor dynamic at play here. When we discuss providers navigating this labyrinth, the default assumption is often, the traditional physician.
Right.
However, a massive and growing percentage of this primary care and complex coding is actually being executed by a workforce that the reimbursement system actively attempts to obscure.
This is the hidden architecture of the clinical workforce. We are talking about advanced practice registered nurses, specifically nurse practitioners.
Exactly. And the historical evolution of the APRN is just deeply intertwined with access to care in this country.
The text traces their origins way back to the late 19th century, with nurse anesthetists stepping in to manage surgical anesthesia, and then the Frontier Nursing Service in 1925 deploying nurse midwives on horseback to drastically reduce maternal and infant mortality in the Appalachian Mountains.
They have historically always filled the gaps left by traditional medical models. And this really culminated in 1965 when Loretta Ford and Dr. Henry Silver established the first formal nurse practitioner program at the University of Colorado.
And that was explicitly designed to combat the severe shortage of primary care physicians in rural pediatric populations, right?
Yes. And today, APRNs are educated at the master's or doctoral level. They are managing comprehensive care, diagnosing, prescribing, they do it all.
Yet, despite functioning as independent primary care providers for decades, the financial scaffolding of the U.S. healthcare system structurally undermines their autonomy. The sources note they weren't even granted direct Medicare billing rights until the 1990s, and even then it was geographically restricted.
And that historical reluctance has embedded a massive structural flaw into modern reimbursement. It's commonly referred to as the incident-to-billing trap.
The incident-to-billing trap. This is one of the most opaque mechanisms in healthcare finance, isn't it?
It really is. So, according to Medicare policy, if a nurse practitioner assesses a patient, formulates a diagnosis, and bills the corresponding CPT code under their own national provider identifier, their NPI Medicare will only reimburse the clinic at 85% of the standard physician fee schedule.
So the exact same clinical labor, the exact same coding complexity is automatically devalued by 15% simply because of the provider's degree.
Simply because of the degree, yes.
Which creates an immediate financial crisis for the clinic's bottom line. So the system designed a legal workaround.
Of course they did. If the nurse practitioner performs the service, but the clinic bills that service under the NPI of a physician who is physically present in the office suite and who initially established the patient's plan of care, Medicare reimburses the clinic at 100%.
The service is billed incident to the physician's supervision.
Exactly. The clinic optimizes its revenue by leveraging the lower salary of the NP while capturing the higher reimbursement rate of the physician.
From a pure accounting perspective, it is a highly effective strategy for maintaining margin. But the macro-level ramifications for the nursing profession and health policy are just devastating.
Because it creates a massive systemic data void.
A data void. Explain that.
Well, if millions of complex primary care visits are being conducted by nurse practitioners, but the claims data submitted to CMS and commercial payers indicates that a physician provided the care, the actual clinical footprint of the APRN workforce is entirely erased from the national database.
So lawmakers, policy analysts, and insurance actuaries, they base all their decisions on claims data. If the data shows the NP doesn't exist, how can the profession prove its efficacy?
They can't. It completely stalls the legislative push for full practice authority. As the text notes, only a fraction of states allow APRNs to practice fully autonomously. The majority requires some form of collaborative agreement or direct supervision by a physician.
And when nursing organizations lobby state legislatures to remove these barriers, arguing that NPs provide safe, cost-effective care, They are frequently hindered because the hard financial data required to prove their value is legally hidden behind incident-to-physician billing. So what does this all mean for ethics? Isn't incident-to-billing technically obscuring reality? I mean, why on earth is the exact same service suddenly worth 15% less just because a highly trained NP did it instead of an MD?
That is the million-dollar question. It is a systemic paradox. The system relies on their labor to function, but financially penalizes the clinic for accurately reporting who performed it.
So for you listening, look closely at your next medical bill. You may have spent 45 minutes with an amazing nurse practitioner, but the bill will likely have a doctor's name on it.
Which means that to survive and advance in this environment, a modern nurse practitioner cannot rely solely on clinical excellence anymore. They must possess an acute understanding of practice management and healthcare economics.
They have to transition from purely clinical thinking to deep financial tracking. The business of nursing is now a prerequisite for professional survival.
It absolutely is. An NP must meticulously audit their own productivity.
Yeah.
They need to analyze their generated CPT codes to understand their case mix index.
They must break down their specific payer mix, too, identifying what percentage of their patient panel is funded by Medicaid, which historically reimburses at much lower rates, versus commercial insurers or Medicare.
Right, because billing a 99284 to Medicaid yields a completely different cash flow than billing a 992004 to a premium Blue Cross plan.
But gross revenue is only one side of the ledger. The source material delves heavily into the operational overhead that an NP must factor into their valuation.
And overhead is huge.
Oh, yeah.
The physical layout of the clinic itself can aggressively bleed efficiency.
The physical layout, like the actual floor plan.
Yeah, operational friction is a massive cost driver. If a clinic's footprint is poorly designed, requiring providers to traverse long distances between exam rooms or work across multiple floors, the physical transit time significantly reduces the volume of billable encounters per shift.
Wow, I never even thought of that. And then there's the transition from legacy paper charts to electronic health records, or EHRs, which involves complex capital depreciation and ongoing software licensing fees that directly impact the clinic's overhead ratio.
Exactly, but the most volatile overhead variable mentioned in the text is human capital staff turnover.
Staff turnover. The data indicates that maintaining a support staff where over 30% of employees have a tenure of less than 1 year acts as a massive drag on productivity.
The constant cycle of onboarding and training just degrades the operational velocity of the entire clinic. It slows down patient throughput and drastically increases the likelihood of coding errors.
So an astutely managed NP must synthesize all of this data, because if they can definitively calculate that they generate, say, $400,000 in gross receipts, and their specific allocation of the clinic's overhead is $150,000, they can quantify their exact net value to the practice.
And this data transitions them from a passive employee to a highly leveraged negotiator.
They utilize that data to negotiate not just base compensation, but reimbursement for the invisible labor of care coordination. We established earlier how critical readmission prevention is under value-based purchasing.
Right, and that prevention requires hours of uncompensated administrative time reviewing discharge summaries, consulting with specialists, managing complex pharmacological interactions.
So if an MP can prove their revenue generation, they can negotiate protected administrative time to execute this care coordination without being penalized for a drop in relative value units, or RVUs.
They also must negotiate their own risk mitigation, specifically regarding malpractice liability. The text highlights the critical importance of understanding tail coverage.
Tail coverage.
Yes, because many clinics utilize claims-made policies, and those only provide liability protection if the policy is actively in force when a claim is formally filed.
Which means if an NP separates from a practice and a patient files a lawsuit 2 years later regarding care provided during their employment, the NP is completely exposed and uninsured unless they explicitly negotiated for the clinic to purchase tail coverage upon their departure.
The clinical and the financial risk are inextricably linked. You cannot separate them.
Which is like comparing the modern APRN to a highly specialized mechanic who is suddenly also forced to act as the garage's chief financial officer, compliance auditor, and customer service representative.
That is very accurate. And this integration of clinical and financial acumen is the exact philosophy driving the evolution of nursing education toward the Doctor of Nursing practice. Yes. The DNP Essentials mandate competency in systems-based practice. The expectation is no longer simply diagnosing the patient. The expectation is diagnosing the operational flaws within the delivery system itself.
Because the entire macro environment is shifting rapidly. The texts outline the trajectory of modern healthcare delivery, the proliferation of telehealth, altering the geographic boundaries of practice, the integration of biometric data via the Internet of Things, and most importantly, the acceleration of accountable care organizations, or ACOs.
ACOs represent the ultimate manifestation of value-based care. They are integrated networks of physicians, hospitals, and outpatient facilities that voluntarily aggregate to assume both clinical and financial responsibility for a defined patient population.
So if the ACO successfully manages chronic diseases, prevents acute exacerbations, and delivers care below the benchmark cost established by CMS, the participating providers share in the financial surplus.
Exactly. And conversely, if they mismanage the population and exceed the benchmark, they absorb the financial loss.
It is a shared risk model that demands intense data surveillance, proactive community health interventions, and rigorous care coordination.
And APRNs, who are structurally educated to focus on holistic, preventative, and systems-based care, are strategically positioned to absolutely optimize these exact models.
So if we synthesize this entire deep dive, the fundamental takeaway is that navigating U.S. healthcare requires abandoning the assumption that it operates as a logical, consumer-driven market.
It is an incredibly volatile ecosystem governed by asymmetrical information, punitive regulatory frameworks, and a desperate systemic pivot toward forcing providers to bear the financial risk of clinical outcomes.
And for you listening, you now possess the blueprint to see through the walls of the clinic. You understand that the frantic typing during your visit is the calculation of an E&M code.
You recognize that the post-discharge phone call is a direct mechanism to avoid a catastrophic HRRP readmission penalty.
And you see the invisible economic constraints placed upon the APRNs who are fundamentally driving primary care access in this country. So champion them.
Understanding these systemic incentives is really the only way to effectively navigate your own care within this asymmetric market.
But I want to leave you with a final provocative mechanism to consider, drawn directly from the system's obsession with value-based purchasing. CMS is aggressively driving toward a future where nearly 100% of reimbursements are tied to these strict value and outcome metrics.
That is their stated goal, yes?
And the intention is noble, right? Enforce quality by threatening revenue. But consider the reality on the front lines.
It gets complicated.
Very. If a hospital's financial survival becomes absolutely dependent on maintaining flawless outcome data, minimizing readmissions, and strictly controlling resource utilization per patient, does that economic pressure eventually cross a critical ethical threshold?
That is the danger of the triple aim.
Are we inadvertently architecting a system that financially incentivizes hospitals to quietly, systematically turn away the sickest, the most socioeconomically complex, and the most vulnerable patients in our society simply to protect their value scores?
It's a terrifying thought.
How does a society reward good outcomes without systematically punishing the providers who are brave enough to treat the hardest cases? It is the defining paradox of the trillion-dollar healthcare economy, something to mull over. Thank you for joining us on this deep dive.